بسم الله الرحمن الرحيم الحمد لله رب العالمين وصلى الله وسلم وبارك على نبينا Muhammad. Welcome back in our series of pathophysiology of congenital heart disease. We have presented on cyanotic congenital heart disease, on acyanotic congenital heart disease, shunts mainly, and we will be talking about pathophysiology of obstructive lesions. I may have the time also today to talk about pathophysiologies of regurgitant lesions, inshallah. So let's take the heart from the start. The heart has the four chambers. The first valve or the first area that can be obstructed is the tricuspid valve. So there are many conditions that can affect the tricuspid valve in terms of obstruction. It could be tricuspid valve stenosis with different degrees. It could be tricuspid valve atresia, which is completely obstructed or completely occluded tricuspid valve. I will concentrate mainly on tricuspid valve stenosis, as tricuspid valve atresia is part of the cyanotic congenital heart disease, and it's a different, more complex lesion. So let's talk now about tricuspid valve stenosis. When the tricuspid valve is stenotic, this is your right ventricle. If I may draw it like that, if this is the tricuspid valve, if it's stenotic, whether it is stenotic down here or stenotic at the annulus, either or, the flow from the IVC and the flow from the SVC, this is the atrial septum. The flow needs to come from the IVC, SVC into the RA and normally just goes to the RV cavity. The end diastolic pressure, the RV compliance, and the size of the tricuspid valve plus the pulmonary vascular resistance will determine whether the flow can go in or not. We're assuming normal compliance, normal vascular resistance, normal end diastolic pressure, and we're only now talking about tricuspid valve stenosis. If the stenosis is mild, only mild stenosis, usually there is no hemodynamic effect. That means the blood still can go in easily and be pumped to the lung. When we talk about moderate tricuspid valve stenosis, that also will mean that the blood will most likely be able to go in and be pumped to the lungs, with one expense that we have to pay is that the right atrial pressure will start to elevate. In mild, most likely the right atrial pressure will not elevate that much. In moderate tricuspid valve stenosis, moderate tricuspid valve stenosis, the right atrial pressure will have to elevate. Normally, the right atrial pressure is anything between 4 to 6, maybe to 8 millimeter mercury. So in a moderate tricuspid stenosis, this pressure may elevate up to anything between 8 to 10 millimeter mercury. You see, the difference is not that much. The upper limit here is only 6, and the upper limit there is only 8, or the starting limit there for tricuspid moderate stenosis is 8 millimeter mercury. The difference is about 2 millimeter mercury. That's quite significant on a venous side, because you have to know that we are starting already with low pressures, 4 to 6 here, something like 6 there, and the whole system is a low pressure system. So a 2 millimeter or a 3 millimeter increase in the difference between the end diastolic pressure of the right ventricle and the right atrium being the higher because of the stenosis, is significant. Obviously, when it becomes severe tricuspid valve stenosis, then we are talking about RA pressure in the range of 12 to higher millimeter mercury. Again, see, the numbers are not that high, but a central venous pressure of 12 and above is quite high for the venous system to really come back normally from the head and neck, arms, and the body back to the right atrium. So the first thing we will notice is that in mild, I said there is not much effect. In moderate, the right atrial pressure will start to elevate. That's fine. We may see as a consequence of that, so right atrial pressure elevating, this is number one, consequence. If it continues, we will have more stenosis, not relieved by surgery or by intervention. Then number two will be right atrial dilatation or enlargement. Right atrial enlargement. Why didn't we say hypertrophy? Because as we said in previous presentations, that actually the right atrium and the atria in general are not muscularized enough to give you hypertrophy, but they will dilate and give us right atrial enlargement. So let's sum up. If I have moderate tricuspid valve stenosis, number one, the right atrial pressure will increase. Number two, there will be right atrial enlargement or dilatation. So what is next to that? Most of the time when it is just moderate, this is all what you are going to get. There will be no effect on cardiac output. The cardiac output will still be able to go through the tricuspid valve and to the pulmonary valve and back to the left side. And the patient will not have significant symptoms or other effects. It's only when tricuspid valve stenosis becomes severe, that is a mean gradient of over 4 millimeter mercury, closer to 5 and 6. And when we say mean gradient, it's equal to the difference between the right ventricle end diastolic pressure and the right atrial pressure. The mean difference between both of them will equal the mean gradient. This being, it has to be the other way because this is the higher number will be. So it's going to be there and there. Right atrial pressure minus RVEDP will give you the mean gradient in the across the stenotic tricuspid valve. And if that mean gradient is over or equal 6 millimeter mercury, then this is severe tricuspid valve stenosis. When we reach severe tricuspid valve stenosis, then we will see the real pathophysiology and a real hemodynamic effect on the patient. So just to recap, we said in moderate tricuspid stenosis, we will see right atrial pressure elevation. We will see right atrial enlargement. So what is next in severe tricuspid valve stenosis? Definitely we will see more elevation of the right atrial pressure to a range of above 12 millimeter mercury. Right atrial enlargement will be severe, and that can be judged by echocardiography, measuring it, seeing the size, and relating that to normal size in normal age, and correlating that with mild or moderate or severe enlargement. If this continues, then we will have for sure the other effects, which we didn't see in moderate. So this is severe tricuspid valve stenosis. We will see starting venous congestion in the body and elevation of venous pressure in the body. So the IVC will start to have high pressure. The SVC will start to have high pressure. What is next to that? Immediately, the hepatic vein pressure will also increase. So if you have inside the liver, the venous pressure or the venous flow will be hindered going back to the right atrium, and the pressure will be high. And that has many consequences on the liver function and liver enzymes, to the extent it can cause liver failure. One of the consequences of this. Other consequences could be developing ascites, lower limb edema because of extravasation of the serum to the extravascular space, and this is seen in the bad cases and the severe cases. For the upper body, we may have facial swelling, elevated intracerebral venous pressure, and because of that, we will have less cerebral perfusion because we depend on a lower venous cerebral pressure for our capillaries and arterioles and capillaries in the brain to perfuse well from the left to the right. Elevation of the right pressure will hinder that flow, and hence we may have decreased cerebral perfusion and cerebral edema if it is really on the extreme side. Upper limb edema, we will see venous dilatations on the upper body and also the lower body if the cause was tricuspid stenosis. And one very important effect that is seen quite common because of right atrial enlargement, what would we see? We start seeing atrial arrhythmias. Most common that we see in such patients would be atrial flutter. And this can go to atrial fibrillation. And we know that can limit the right-sided cardiac output severely. Not only that, it causes, if we go to this arrhythmia stage, it will cause blood or venous blood stagnation and clot formation or thrombus formation in the atrium. See, it is quite serious disease, and because it's happening in a low pressure system, a moderate to severe stenosis doesn't take too much pressure to start showing its deleterious effects on the body. And obviously, once we have that venous congestion and have the effect on the organs, we talked about the liver, the brain, the abdomen with its content, the lower limbs, and so on. So would the cardiac output also be affected? Yes, it will be affected. In such a stage, we can see low cardiac output state, LCO. Luckily enough, and sometimes maybe not so lucky, a lot of these patients with tricuspid stenosis, which is severe, we do see them in real life, so they are living in spite of that low cardiac output state. So what is making them remain alive? A lot of the time in severe tricuspid stenosis, if I may draw the atria, IVC, SVC, right atrium, interatrial septum, and left atrium. A lot of those patients will have the patent foramen ovale still open. That means they do have a communication between the right atrium and the left atrium. So if the tricuspid valve here, let's say, is severely stenotic, nothing much able to pass, then the blood, when it elevates the pressure, when it gets congested, will have to shunt right to left to there, and then to the mitral, and then get pumped to the aorta. So the cardiac output to the left side will be maintained, but on the expense of significant cyanosis because of the right to left shunt. So in severe tricuspid valve stenosis, we do see quite a bit in these patients a patent foramen ovale with a right to left shunt across the septum, causing the cyanosis but maintaining the cardiac output. One of the effects of significant tricuspid valve stenosis, if it happens early in utero, early in the uterine life, we may see right ventricular hypoplasia or even aplasia or severe atrophy. Why? If you believe in the theory of volume and flow, then because of being not receiving enough blood, the right ventricle will not have its normal volume, but actually may look like this. So a smallish right ventricle with a stenotic tricuspid valve, and the rest is a left ventricle with the atria being up there. You see, this is one of the effects of significant tricuspid valve stenosis or atresia or near atresia. By this, I think we have covered significantly most of what is related to the tricuspid valve obstruction, which is tricuspid valve stenosis, to the range of atresia. We have said that mild are usually asymptomatic with no much hemodynamic or pathophysiological effect. Moderate, we have mostly right atrial pressure dilatation and some right atrial pressure elevation and some right atrial size enlargement or dilatation. And with the moderate to severe or the severe, we start seeing all the other effects that were mentioned. The next lesion I will be talking about for obstructive congenital heart disease, we are taking it from right to left. We spoke about the tricuspid valve. We will now talk about the pulmonary valve stenosis, which is another obstructive lesion that we see on the right side. So if this is the pulmonary artery 3, this is being the left pulmonary artery, the right pulmonary artery, the main pulmonary artery, MPA, and the pulmonary valve. And this is the sub valve area, what we call the right ventricular outflow tract, RVOT. So stenosis can happen in the pulmonary valve, just above the pulmonary valve, or just below the pulmonary valve. All of them constitute what we call right ventricular outflow tract obstruction, RVOT. Subpulmonary stenosis, suprapulmonary stenosis, this is sub, this is the muscle that's causing the subpulmonary stenosis, so this area is now less, or the valve itself may actually be thickened and obstructed. 3 levels of right ventricular outflow tract obstruction: suprapulmonary stenosis, pulmonary valve stenosis, and subpulmonary valve stenosis. Again, we divide them into mild, moderate, and severe. In the mild forms, again, there is only elevation, mild PS, let's call it. There is mild elevation of right ventricular systolic pressure. And that's probably it. Nothing more than that. Normal right ventricular pressure is anything between 15 to 20 millimeter mercury, with a pulmonary pressure, pulmonary arteries pressure of almost equal numbers. When we have mild supra-PS, mild sub-PS, or mild valve PS, which I will concentrate on, then the elevation is usually, the RV pressure is usually less than or equal 40 millimeter mercury. This is systolic elevation, It's systolic pressure. We're not talking about anything but systolic pressure in this stage up to now. So mild PS will elevate the right ventricular systolic pressure slightly to less than or equal 40 millimeter mercury. The right ventricle can handle that quite easily. The hypertrophy of the right ventricle, because it's now pumping against an obstruction, is either negligible or mild, or even not seen at all on echocardiography, but may be appreciated a bit more on ECG. The function of the right ventricle will remain normal. The flow from IVC, SVC, right atrial, going to the right ventricle will also not be affected. We will not have venous congestion. We will not have elevation of the right ventricular end diastolic pressure. And we will maintain the cardiac output to the branch pulmonary arteries. Again, here you will see that the pressure difference, this is 40 here. This is the right ventricle outflow. So this is 40 below the obstruction. And we said before the RV pressure normal systolic is between 15 to 20. And the PA is the same. So let's say, just for simplicity, it's 20 here. See, the gradient or the difference in gradient is around 20. It can be even a little bit more, but I'm taking the cautious side. that means a gradient of up to 40 can also be considered mild, but then your RV pressure may be 60, and that's a moderate elevation of RV pressure. So I'm taking the cautious lower limit to describe mild PS in this talk. So no significant hemodynamic effect, and hence no significant pathophysiological effect to talk about, except the mildly elevated right ventricular systolic pressure. This, even if it continues for a long time, will have almost no significant effect on the patient, and will give us not much of pathophysiological effect. Okay, so let's now talk about moderate. Again, moderate PS whether this is sub-PS, valvar PS, supra-PS, moderate PS will also elevate the right ventricular systolic pressure. But this time, the right ventricular systolic pressure will be elevated between 45 to 60 millimeter mercury. Obviously now we're seeing higher right ventricular systolic pressure. The pulmonary artery pressure will remain the same. And now this is the PA pressure, pulmonary artery. We have a gradient of almost 40 millimeter mercury happening between the lower PA pressure and the higher right ventricular pressure, because now it needs to pump against a moderate obstruction, moderate pulmonary valve stenosis. Let's talk about cardiac output in this stage. Like we said, in mild pulmonary stenosis, the cardiac output will be maintained. Also here, the cardiac output will be maintained, although it's moderate stenosis. So we will not have any effect, any pathophysiological effect on the cardiac output. Number two, do we have any pathophysiological effect on the right ventricle? Yes, we will. We should start seeing, so elevated pressure, number one. Number two, we should start seeing right ventricular hypertrophy, though not severe, maybe just mild to moderate. But we start seeing that because now the right ventricular muscle needs to hypertrophy to respond to the increased obstruction and to be able to push the cardiac output in the pulmonary tree. Would we start seeing any venous congestion? No. So no venous congestion in the right atrium or in the venous system. No venous congestion. Would we see any effect on right ventricular end-diastolic pressure with moderate pulmonary stenosis? We should not see significant effect on RV-EDP or right ventricular end-diastolic pressure. Why is that? Because we do not have significant RVH and because we do not have congestion. So the RV end-diastolic pressure will almost remain normal, not affected much even in moderate PS. So mild to moderate PS usually does not give you much hemodynamic effect, but you see that we start seeing this effect actually with moderate. Now, if we go to severe pulmonary stenosis, we will start seeing the real effect on the right side of the heart. So again, in severe pulmonary valve stenosis, the obstruction, whether it is subpulmonic, or at the valve, valvular stenosis severe, or supravalve stenosis. This is severe. Just write it there now. Obviously and definitely we will have elevated right ventricular systolic pressure. How much elevation? Obviously above or equal 60 or 65 if you want to be more towards an accurate number, 65 millimeter mercury. So now we see the right ventricle is seeing a pressure of almost near or equal to the systolic pressure. Imagine if this is a baby with a systolic pressure of 80 millimeter mercury and the right ventricular pressure is 65. That's quite high. Not only that, knowing that the normal RV pressure is around 20, this is now 65. So that's about 3 times. And we know any pressure that elevates more than 2.5 to 3 times, then it's usually a severe elevation in the cardiac chambers. So 65 millimeter mercury or more in the right ventricular systolic pressure. The PA pressure will be maintained the same, around 20. There will be at least moderate right ventricular hypertrophy, if not severe RVH. Why? Now this is a severe obstruction. It necessitates a lot of effort on the right ventricle, and that will cause significant right ventricular hypertrophy. End-diastolic pressure, what will happen to the end-diastolic pressure? It will definitely be higher. So end-diastolic pressure will have to elevate. You see, now pushing the cardiac output through this severe stenosis with significant RVH will lessen the right ventricular compliance, and with that, the end-diastolic pressure will have to elevate to be able to get all the cardiac output and pump it. So right ventricular end-diastolic pressure will start high. We will start seeing venous congestion only if this severe stenosis become critical. So in severe stenosis, we have significantly elevated right ventricular systolic pressure, significant right ventricular hypertrophy, elevated right ventricular end-diastolic pressure, but not yet RV failure, neither systolic or diastolic. We will only start seeing RV failure and venous congestion if the ADP becomes very high or the right ventricular systolic function after being severely affected by hypertrophy starts now to lose effort, to lose function because of the obstruction. That, in another word, the right ventricle is pooping out. It cannot keep continuing, and that usually takes a long time. Even in severe PS, children with congenital heart disease of severe PS will also be able to maintain their cardiac output because of good systolic function and not severely elevated right end-diastolic pressure. And usually, they even do not have the patent foramen ovale open to give them the relief or the maintenance of the cardiac output, like we spoke in severe tricuspid valve stenosis. They will not have it, and they will still be pink, and they will be able still to maintain their cardiac output for months and years of severe pulmonary valve stenosis, not just a few days or weeks. It's usually months to years before this severe PS starts to affect the systolic function, elevates the right ventricular pressure so much that the cardiac output cannot be maintained. We get the venous congestion, and at that stage, you may see the right to left shunt. If this is the atria, You may see the right to left shunt from the right atrium to the left atrium, causing the cyanosis. And in that stage, we will not call it anymore severe pulmonary stenosis, but we will call it critical pulmonary valve stenosis, and that can really lead to a low cardiac output state. So this, I hope, covers pulmonary valve stenosis, or pulmonary right ventricular outflow tract obstruction. Sometimes branch pulmonary artery stenosis are included into that, but for the sake of RVOT, this is the main things: the subpulmonary stenosis, the valve stenosis, and the supravalve. In the next part, I will be talking about branch pulmonary artery stenosis and their pathophysiological effect. From there, we will move to the left side. So we just finished tricuspid valve stenosis, pulmonary valve stenosis, subpulmonary and suprapulmonary pathophysiology. Now we will move to the branch pulmonary artery stenosis pathophysiology. So this is the pulmonary artery tree again. Left pulmonary artery, right pulmonary artery, and the pulmonary valve with the main pulmonary artery. So our area of interest is here and here, whether proximal or distal, proximal or distal. So the branch pulmonary arteries are blood vessels. They are no more cardiac chambers. They do not hypertrophy. They may dilate or become small, either or. When we have significant branch pulmonary artery stenosis, see the lumen is significantly narrowed for whatever cause of stenosis, congenital, whether this is in an association with lesions or in isolation, whether this is bilateral or unilateral, it can affect significantly the lumen where the blood flows. This is what we call PPS, or peripheral PPS, peripheral pulmonary artery stenosis of variable degrees. You can imagine so many combinations and so much degrees of such stenosis. And again, I said it could be unilateral or bilateral. Again, we will classify it into mild, moderate, severe, unilateral, or bilateral to talk about the pathophysiological effect of such disease. Mild PPS is, again, like any mild stenosis in most of the parts of the heart, will usually cause no effect. What do we mean by mild gradients or mild PPS? We said before that the pressure here is normally around 20. If there's a gradient between the main pulmonary artery and the distal branch pulmonary artery beyond the obstruction of around 15 to 30 or 25, let's say, millimeter mercury mean gradient difference, which means if I add this 15, this could be here, let's say, maximum 45, and here it will be 45, and we have a gradient of 25, so here it's around 20. okay? The gradient here now is around 25 millimeter mercury, and for sure above 20, where we really consider it mild, then this is a mild stenosis. Whether it's unilateral or bilateral, there is some effect, there is some cumulative effect. We'll talk about unilateral, mild PPS. Usually it does not cause any pathophysiological effect. And there is something called normal or physiologic peripheral pulmonary stenosis that we see early in life, immediately after birth, that usually resolves completely beyond or before the age of 6 months. Pathological PPS, when it's mild, it does not cause any hemodynamic effect if it is unilateral, but if it is bilateral, let's say we have a gradient here of like 25 and another gradient here of 25, this pressure may not remain 45. It may go up to 60 millimeter mercury. And then what really concerns us is, because of the cumulative pressure gradient effect, then the RV pressure, RV systolic pressure, will also be high. And then we'll start seeing some effect of mild PPS. So mild PPS, if unilateral, no effect, no hemodynamic effect, except mild elevation of the pulmonary artery and the right ventricular systolic pressure. If it is bilateral fixed obstruction, then we do see a moderate or slightly more than moderate, usually moderate effect on the right ventricular systolic pressure and the MPA. So if we start seeing moderate PPS, see the difference now? A bilateral mild can give you a moderate effect, while a unilateral mild does not give you that much effect. If we said 15 to 25 for a mean gradient difference between MPA and the branch pulmonary artery for mild PPS, what if the mean gradient is anything between 25 to 40 millimeter mercury difference between the MPA and the branch pulmonary artery? So if it is, let's say, 40 plus 20, then this now will become 60, see? So this is now 60 millimeter mercury. The gradient is 40 between the main pulmonary artery and the branch pulmonary artery stenosis. Again, in moderate PPS, usually there is not much of significant pathophysiological effect. Why? Because as in mild, the pressure does elevate, but the right ventricle can take it. The cardiac output can be maintained, although there is an obstruction. We talked about that having bilateral mild may make it moderate stenosis, and having bilateral moderate stenosis, let's say these two are existing, not just one of them, actually this pressure may even go higher and become above 70 millimeter mercury. And then it's now turned into severe effect on the right ventricle and the pulmonary artery pressure. We have now significant severe elevation because of bilateral moderate stenosis. This is quite important to understand. So I'll say it again, mild PPS alone on a unilateral side with a normal other side usually causes no effect and not much elevation of the pressure, and it is well tolerated, except that the lung receiving that stenosis maybe slightly underperfused, not significantly underperfused, slightly underperfused. If we have bilateral mild, we may have a moderate effect on the right ventricle. If we have bilateral moderate, we will have a severe effect on the right ventricle. And that's really what concerns us, because that's the pump that's pumping against this obstruction. And what if we have severe bilateral or unilateral pulmonary, peripheral pulmonary artery stenosis? Then the gradient or the pressure gradient between is anything between 45 millimeter mercury to 60 millimeter mercury. So if we apply that, 20 plus 60, this number will become 80. So again, you start seeing significant obstruction. And if it was bilateral, let's say this is 60 and this is another 60 here, this number can go up to 100 to 120 millimeter mercury. Extremely severe, and that will be the right ventricular systolic pressure. So in PPS, one of the lung, if it is a good lung, if it is good size, if it has no stenosis, it actually can take most of the cardiac output and the pressure, and this will not elevate. In such sense, mild PPS unilateral is asymptomatic, moderate PPS unilateral is asymptomatic, and even severe PPS unilateral can be asymptomatic, although some of these patients actually complain of dyspnea on exertion. And when I say symptomatic, I mean by clinical. And here we really talk about pathophysiological. So let's agree, in mild PPS, not much pathophysiological effect, even on both lungs. The only thing, if it is bilateral, it can give us moderate elevation of right systolic pressure. With that, we may have mild right ventricular hypertrophy. We will maintain the cardiac output. We will not have significant end-diastolic pressure elevation, and we will not have venous congestion on the right side. When it is bilateral moderate PPS, then we may have severe elevation of the right ventricular pressure in the range of more than 65, more like 70 to 80 millimeter mercury. Then we do expect right ventricular hypertrophy. We may expect right ventricular end-diastolic pressure high. The cardiac output will be still maintained on the expense of RVH and elevation of end-diastolic pressure. We will not see significant venous congestion or RV failure. When it is bilateral, severe PPS, peripheral pulmonary stenosis, then the pulmonary artery pressure will be extremely high in the range of 100, 120, and in that we will see significantly high, very high right ventricular systolic pressure, significant right ventricular hypertrophy. We will see elevation of the right ventricular end-diastolic pressure. We will see significant venous congestion if it is continued for enough time to give us some sort of RV failure. Not necessarily the florid complete RV failure with zero function, but a form of RV failure with congestion, right atrial dilatation, tricuspid valve will start leaking. We will have tricuspid valve regurgitation, the pulmonary valve will also start leaking. We will have, because of the high pressure here, this valve cannot maintain in systole, in diastole, the elevated pressure, and will also start leaking. And in that stage, it will add to the ventricular hypertrophy. It will add to it ventricular dilatation. And this is really the worst stage, because in that stage, we start losing the strong RVH that can push through a severe obstruction. We will also start seeing the end-diastolic pressure being high, the venous congestion, and that should not be left to reach such a stage. We interfere in PPS even if they are moderate, especially if they are bilateral. So to sum up again, branch pulmonary artery stenosis are usually well tolerated, mild to moderate, and even severe if they are unilateral, because the other lung will take over. Just a caveat there, when it's moderate to severe, the pathophysiological effect will appear on the lung receiving the blood through the stenotic area. It may become smaller volume, less perfused, even to the extent it may become hypoplastic. It may actually even lead to hypoplasia of the pulmonary veins of that same lung, and that's quite a bad effect. So even if it's unilateral, then the effect, but it is severe, the effect will not be on the right ventricle, it will be on the lung receiving and on the size of the pulmonary artery receiving that diminuted or less blood because of the severe stenosis. The major issue with PPS is when they are bilateral. Bilateral mild PPS will give you a moderate effect on the pulmonary artery, maintaining the cardiac output on the expense of an elevated right systolic pressure with a usually normal EDP and no venous congestion and not much tricuspid valve regurg or pulmonary valve regurgitation. But when it becomes moderate or severe bilateral PPS, then we will have significantly elevated RV systolic pressure and pulmonary artery, pulmonary valve regurg, significant right ventricular systolic pressure elevation, right ventricular hypertrophy, elevation of the right ventricular end diastolic pressure, and late stage venous congestion and RV failure. This is the outcome of PPS in a nutshell, as they say, and I hope I made it clear and somewhat easy to understand. From this, we will move to the next obstructive lesion, but this time we will be going to the left side.